Okay, greetings all. Let's now talk about endocrine disorders that you'll see in critical care settings. So the endocrine system as a whole is made up of huge components of many different processes within the body. You can see the vast majority of the groupings of their processes listed here. They do this through their composition of glands. Right? We have glands all over our body, and they secrete and create and sometimes release certain hormones. So when we utilize these hormones, we remember that these are chemicals, right? Hormones are chemicals that coordinate different functions of the body by carrying messages to the various components. And sometimes they kind of have that cascade effect, right? We need one set of hormones to work on something, so then another set can work on another thing. So again, in this way, it signals to tell your body what to do and how to do it and when to do it.
Okay, so hormones are signal molecules that are released into the blood that have their intended effect on a cell that has a specific receptor for the hormone. So when you think of the concept of upregulation, the cells make more hormone receptors. If we're looking at downregulation of endocrine function, the cells are going to make fewer hormone receptors. So let's just dive a little deeper into that. So endocrine function really has this type of lock and key to it, right? Like lock and key concept. This is where the hormone represents the key and the lock can be interpreted as its receptor. So the location of the lock is on the target organ of where the hormone is intended and designated to interact with. The target organ will then have that physiological response of the hormone or possibly release another hormone in the intended pathway. So the main function you are pretty familiar, I'm sure, with majority of the endocrine system. One that may not be as familiar is the pineal gland. And this one is to receive and convey information about the current light and dark cycle from the environment. And consequently, the pineal gland produces and secretes melatonin at night, again, during the dark period of Earth, right? The main function of the pineal gland is to receive that information effectively. So with its position on the top of the third ventricle, it really allows for that direct secretion into the cerebral spinal fluid, hence why we get tired usually at night. This can be very difficult, as most of you, many of you, might be on night shift, either as new grads or by choice, staying on night shift in your careers. And so sometimes your pineal gland can play a really difficult role in helping to adjust. I've had some colleagues that are able to just go back and forth, right, from days and nights very easily, where others, myself in this, had a really difficult time staying awake at night during my early years as an RN. And that's why I would need to take the most difficult, sickest patient possible just to keep myself going all night long, because I had a very sensitive pineal gland that was ready to go to sleep. So in addition to the lock and key mechanism of hormone pathophysiology, there's also these different categories that indicate kind of the effect and the overall genetic makeup of the hormone itself. So permissive, synergistic, or antagonistic. For example, permissive means one hormone is needed for another one to take effect. An example of this includes thyroid hormone. It's necessary for growth hormone to have its proper effect in maturing the child to the adult state. Not enough thyroid hormone will stunt the complete effect of growth hormone in the body. Hence why this is something you will also be measuring in the pediatric population. An example of synergistic. So sperm, as we know, is produced from the follicle stimulating hormones effect that originate in the pituitary gland. Sperm's actions and effect, however, are further enhanced or increased with the hormone of testosterone. So again, it's that synergism of those two things that come together. Let's look at antagonist. You probably have heard this term from your pharmacology days, but it also can be descriptive of different hormone actions within the body. So antagonistic, take into consideration progesterone and estrogen. So estrogen, as we know, releases, and estrogen release promotes the continuity of the assigned female at birth reproductive system. So estrogen and progesterone both cause uterine linings to thicken, right? This is a good thing when the desire to procreate is present, right? Estrogen, however, also causes contractions after the lining is thickened, hence to expel the lining if conception has not occurred and menses will occur. This is where progesterone comes in to block the estrogen receptors on the uterus to prevent or antagonize from contractions from the effects of estrogen. In some pregnant people, they will need to have supplemental progesterone to keep a pregnancy going, as some people do suffer from a low progesterone after conception. Let's spend some time looking at some pituitary pathophysiology. As we remember from A&P days, the anterior pituitary has a host of different hormones and endocrine functions that come from it. This is just a brief reminder of all the different things. Adrenocorticotropic hormone, we're going to be speaking of that in the next slide. Very responsible in the HPA axis for cortisol levels within the body. Growth hormone, again, it's going to be looking at growth, metabolism, composition of the body, most notably effective during those childhood and adolescent years. Thyroid stimulating hormone, you have a presentation on Hashimoto's that I encourage you to review for your upcoming exam. We will briefly talk about thyroid storm as well in this lecture. The gonadotropins, again, those that influence the gonads, and again, the reproduction organs. Again, we're going to talk briefly about luteinizing hormone and also FSH. One that's really commonly discussed within the OB settings is that of prolactin for those to stimulate milk production. These are good to know for the upcoming exam 3. Let's look at them a little more in depth each. So referring to the figure on your left first is the hypothalamic pituitary adrenal axis, which is more commonly known as the HPA axis. And this is a complex set of direct influences and feedback interactions among the 3 components of the hypothalamus, the pituitary gland, and the adrenal glands. So when we perceive a threat, you have corticotropin releasing hormone that is released from the hypothalamus. With CRH, it's produced within the paraventricular nucleus of the hypothalamus. And with its release, this triggers the release of adrenocorticotropin hormone, or ACTH, in the pituitary gland. So with this, you start to have, again, this further action on the adrenal cortex, which will further release cortisol. So the body has this built-in mechanism for closely monitoring at each step of the HPA axis as a feedback mechanism to regulate the stress response. Again, remember we talked about stress way back in week 1. When we have this increase in cortisol release, we know that cortisol will increase blood sugar levels. It also suppresses the immune system and increases metabolism. So with this, especially with high levels of cortisol and their high suppression of the immune system, we need to try to keep cortisol levels at bay, right? Because they do show an increase in length of wound healing time, again, increased blood sugar levels, and overall, worsening of potential for heart disease and all the other things that come with this constant inflammation stressed state due to increased cortisol. So this can be a bit complicated. So let's try to say it a different way here. So this HPA axis response is the physiological response that activates the body to respond to a threat. So when a threat is detected and perceived by the amygdala, you have this physiological response that occurs, right? Because of this hypothalamus anterior pituitary gland. So with this, you start having corticotropin releasing hormones, or CRH, that's produced, and then triggers the anterior pituitary to release ACTH into the bloodstream. ACTH then triggers the release of the glucocorticoids like cortisol from the adrenal cortex, right? Those glands that sit right above the kidneys. If there's enough cortisol produced in the body, you see you have this negative feedback loop, either affecting directly at the anterior pituitary or all the way back up into the hypothalamus and trying to maintain homeostasis. Let's spend some time on the middle one now. This is in regards to the gonadotropins, endocrine system. So with this, you see luteinizing hormone, or LH, right, and follicle stimulating hormone, FSH. These are both called gonadotropins because they stimulate the gonads. Again, in those assigned male at birth, this is going to be the testes, and those assigned female at birth, these are going to be the ovaries. Now, the gonadotropins are not necessary life, but they are obviously very essential for reproduction. So when we have luteinizing hormone, or LH, this is going to stimulate secretion of the sex steroids from the gonads, from the target tissues, which are the gonads. Again, in individuals with testes, you have luteinizing hormones that will bind to receptors on something called the Leydig cells, which stimulate the synthesis and secretion of testosterone. On the other side, then we have the theca cells, and that's THECA, theca cells within the ovary that respond to luteinizing hormone, which is then will help to foster and stimulate with the combination of FSH in the maturation of the ovarian follicles. Finally, let's look at growth hormone, the right-hand side picture. So growth hormone, again, growth hormone induces growth in nearly every tissue and organ of the body. You probably see most of its profound effects for growth promotion on the effects of cartilage and bones, especially within the adolescence years. This is where you start having the child just immediately seems immediate, shoot up to adult size height or even higher than their parents' height, in a very small amount of time. So with this, we have something called chondrocytes and osteoblasts that help receive signals from the effects of growth hormone to increase replication and allow for an increase in growth and size. This also will, at time of maturation, again, for those assigned female at birth, it's usually around 15 years or so. For those assigned male at birth, growth can occur until 21, 22 years of age. But again, it has that feedback when we get to that certain age where growth hormone will not be as effective and the person will stop growing any taller. So the pituitary gland, both anterior and posterior, play major roles in regulation of a wide range of biological functions within the body. In particular, anterior pituitary secretes hormones involved in metabolism, growth, blood pressure, and also sexual maturation and function. So when we have a disease of the anterior pituitary, often you can see a decrease subsequently in secretions of the pituitary hormones. You can also see an overproduction in hyperpituitarianism that can occur. So let's talk a few minutes about that. Sheehan's syndrome I will be discussing in the next slide. With a hyperpituitarianism, again, you see commonly comes from a benign adenoma. It can lead to a couple of disorders known as acromegaly and gigantism. So acromegaly typically results from secreting pituitary adenoma, usually with the the onset of closure of those growth plates, so typically in adulthood. So with this, you start having bone growth that primarily affects the flat bones, like the skull and the mandible, sternum, the hands, the feet, right? Sometimes patients will come in and say, I just feel like my hat isn't fitting anymore, or maybe my hands just seem to be growing in substantially more than I think they should be, right? And you will see this acromegaly, or this really enlargement of these flat bones that occur. Treatment for acromegaly tends to consist of surgery and radiation therapy to try and target the area of the underlying adenoma to help hopefully keep the growth hormone down. And so they don't create more and more, a really increased size. Gigantism, so this is it's very similar to acromegaly in all aspects, except the underlying pituitary adenoma develops before the closure of the long bone epiphyses. So again, this is going to occur in children, right? And young adolescents. So with this, you start seeing bone growth that occurs in the long bones, like the tibia, the fibia, the femur, the humerus, and the radius, and the ulna. Since the epiphyseal closure occurs before adulthood, this is where we're going to see a very long-limbed child, very large for stated age. In terms of the internal effects, like on organs and metabolic impacts, they're going to be very similar to what you see in those of the individuals who have acromegaly. A good example of this was, I believe, Andre the Giant. I think he was in a movie, Princess Bride. Just a very large, body habitus. But the problem is you also have issues with the organs. And I believe he actually passed from cardiomegaly as a result of a lot of increased work of the heart, trying to supply blood volume to such a large body habitus person. So Sheehan syndrome, like I mentioned before, Sheehan syndrome is hypo, so low pituitarianism, that results from a postpartum pituitary infarction that leads to subsequent necrosis. This occurs after a severe hypothalamic event, such as like a massive bleeding after delivery of a baby. You'll often see that failure to lactate is one of the most common associated factors long-term associated with this syndrome. You can imagine, though, in the immediate effects of Sheehan syndrome is you're going to be controlling for the massive blood loss. So I have actually seen these patients being an ICU nurse because they are transferred to ICU after delivery for support of their systems while we get their blood levels back up. So with the acute stages of Sheehan syndrome, you see the inability to lactate, profound hypotension, tachycardia, think about the sympathetic nervous system response. You also see hypoglycemia, so you're kind of chasing these sugars as well. Once we get them with blood replacement, fluids, try to get them more stable in terms of vascularly, you often will see a more chronic stage of a continued inability to lactate. Some people will experience changes to their overall menstrual cycle once it returns. They may even complain of libido changes. Hypothyroidism is a really common one that is associated with this. And again, treatment's going to be on hydrocortisone sometimes, and usually lifelong levothyroxine sodium replacement as well. And a brief discussion on the posterior pituitary. Again, ADH is a big one, and we're going to be revisiting this when we talk about SIADH soon. But again, we know what antidiuretic hormones, obviously by the name, it means no urination, right? Antidiuretic. And it's produced by the posterior pituitary in the body to help regulate water and electrolyte balance. Another one that we may remember from our OB rotations, or those of you who are still in L&D, is oxytocin, right? This one, we know it's involved with uterine contractions for childbirth to get that process going of labor. It's also referred to as the love hormone, oxytocin. So it's a neuropeptide that is produced in the hypothalamus and then released from the posterior pituitary to bind to many different oxytocin sites in the body. Again, as we said before, this is going to be a crucial hormone for assisting to get labor going, right? And then in individuals who have delivered a baby, it's going to help start their milk to let down in those who are chest feeding parents. What we also see, though, outside of the L&D and childbirth setting is that this level of oxytocin will rise with friendship and love, right? You remember that oxytocin, dopamine, and serotonin are commonly lumped together as the happy hormones, right? So when someone is spending time with loved ones, close friends, or even pets, their oxytocin levels rise and they feel better about life. So again, kind of interesting different components of this hormone within the body.
So now let's look at a couple fairly more common, although not seen too much, but again, the more common of the rare forms of ADH issues in the critical care setting. The first one I talked about in class was by the name of diabetes insipidus. Again, it kind of throws you off because it really is not a diabetic issue. It's an ADH issue. We refer to this often as DI. Two types of DI. And again, it's an ADH issue. Central is going to be the pathophysiology of central or neurogenic DI deals with the pituitary isn't producing enough ADH. And with this, the kidneys don't know to concentrate the urine, so you have a large urinary release, polyuria. This was the more common of these two. The second one that's not as common is the nephrogenic. So again, with nephrogenic, you have the pituitary gland that is making enough ADH, but for whatever reason, the kidneys aren't responding to it. And they, again, will have this polyuria effect. Sequela. Etiology of this can be multifactorial. The most common time I've seen it is following a head trauma patient, but it can follow with patients with brain surgeries in any situation that could create an increased intracranial pressure. Just some serum laboratory indicators that might be useful in your clinical setting. Again, you remember I was talking in class about monitoring the level of osmolality in terms of normal versus high and also low. And again, when we start seeing this patient, we're going to see a huge amount of hyperosmolar state because we're going to have an incredible urine output, right? That's going to leave the body intravascularly dry. Again, these are not really for memorization, more just to be applicable to your findings. So looking for the serum hypernatremia, right, with DI. And as we start to treat DI, hopefully we'll see our serum sodium and osmolality come much back down to normal. Okay, so how does the vasopressin test help to diagnose the type of DI? Well, we kind of talked about that, right? When we give vasopressin, if we have a positive response on part of the kidneys by able to concentrating more urine, then we're going to know that this is much more of a central or neurogenic diabetes insipidus. If we give the vasopressin and there is no results, in other words, that they still keep having vast urine output that's very dilute, low specific gravity, then we know the diagnosis is more going to be leaning towards nephrogenic diabetes insipidus. Again, not for memorization, but just a brief review from your book, the role of ADH in our body. Okay, as the name implies, right, this is our mechanism that we have in maintaining adequate volume levels within the body to maintain blood pressure. And it's signaled or stimulated when the body senses a decrease in overall circulating volume via decreased blood pressure often. This is where those baroreceptors come in. This is where those stretch receptors come in. And what it's going to do is send that feedback to the hypothalamus to tell the posterior pituitary to let's release some ADH. And why is it doing that? Because we're going to want to increase water reabsorption at the kidney level. It also will signify to the body to create a bit of a vasoconstriction type of process, further helping and benefit increase of blood pressure. It's going to decrease urine output. Again, as the name says, it's an antidiuretic, right? So with the goal of increasing that intravascular volume. Okay, for the last part of this lecture, let's look at another critical care component that involves ADH. But unlike diabetes insipidus, this one is going to be SIADH. You remember I said in class it's syndrome of inappropriate secretion of antidiuretic hormone. I want you to replace inappropriate in your notes with increased, because that's what it does. So it's the opposite of diabetes insipidus in terms of its effect on the body. You're going to have this overwhelming retention of fluid in the body because the ADH is in full effect, right? So we have the antidiuretic hormone that is not allowing normal diuresis. This is going to increase overall circulating serum. It's going to create this kind of waterlogged type of body presentation. Many different components could be the etiology findings for SIADH. Again, I said it before, in my patient population, I've seen this as a result of malignancies, most often Hodgkin's and small cell lung cancers, but again, many other components. And so the treatment is really going to be identifying the cause and treating the cause, or if it's the etiology is a medication, stopping at the medication. So assessment with SIADH patients, again, we're going to have an overwhelming of body volume. So it makes sense why, depending on their other comorbidities, you could see profound issues with pulmonary and cardiovascular due to this overwhelming volume that's entering to the right atrium with each and every heartbeat, right? Elevation of CVP, right, greater than 6. PA pressures high. If they have any history of any pulmonary issues, especially heart failure, this could be especially problematic, right? And so we need to monitor them very closely. Common laboratory indicators, again, when you associate with a high amount of intravascular over body water, you're going to have dilutional hyponatremia in terms of lower sodium, right? You're also going to have a hyperosmolar state because you have an overwhelming amount of serum, but not much solutes. It's all very dilute, right? And you're also going to see a higher amount of sodium excreted because, again, once we do start, the body's going to try to pull some of the water out with that homeostatic mechanism in the collecting duct by having a higher amount of salt in the urine to hopefully help to pull some extra water from the vasculature to help excrete it out. I like this slide because it's a nice review of what functions in the body in a non-disease state, i.e. someone that does not have diabetes. So after we eat a meal, blood glucose levels rise from the content of the meal. This increase in serum glucose triggers the pancreas to release insulin. Insulin activated has that conversion of glucose to glycogen within the liver, right? Stores that. Hence, with that conversion of the glucose to the glycogen in the liver, we have an overall decrease in our blood glucose levels to maintain a normal amount, right? Anywhere from 70 to about 110. So let's talk now about when our blood glucose level falls, right? When we have low sugar, our blood glucose level falls, the alpha cells in the pancreas release the glucagon, right? Liver breaks down glycogen with this glucagon release and releases glucose. And therefore we have a maintenance of our blood sugars. They rise up, and to keep us, again, in that homeostatic numbers anywhere between 70 and 110. So when we have this imbalance that comes into play with either type 1 diabetes or type 2, you can see where all those homeostatic methods get thrown off and why we start having increased amounts of blood sugar with insulin resistance, where the cells aren't able to receive the glucose appropriately because the insulin is not able to carry it through into the cells. And we start having people who have higher and higher and higher levels of blood glucose.
Let's look at type 1 diabetes patho. Remember, type 2 is going to be discussed by some of your colleagues' presentations, so be sure and look at those. In terms of type 1, however, this is often where you have that diagnosis of diabetes, when there's this misalignment of glucose present in the blood that's not being able to be moved into the cells. As we know, cells need glucose as a source of energy. This can and does lead to changes over time within the cell. So think about all the complications of the target organs that are associated with improper glucose in the cells, metaplasia, atrophy, all those things that we talked about in weeks 2 and 3 of this course. This balance of sugar in the blood and in the cell is controlled really by two hormones of insulin and glucagon. So insulin, as we know, reduces blood glucose levels by moving it into the cells. Glucagon is used to increase serum glucose levels, and it does this by stimulating the liver to produce more glucose molecules, and also can stimulate the liver to break down more glycogen so that glucose can be moved into the serum when necessary. Again, we have this balancing act that's present in the body, right, in the non-disease state. Now, when we enter into the disease state, and oftentimes type 1 is going to be the autoimmune presentation that you see here in the slide pictures. Although it doesn't seem it, the autoimmune is a slow, progressive T-cell mediated disease that destroys the pancreatic beta cells, like you see here. And you have these autoantigens that are formed and are present on the beta cells, which then go into the bloodstream. You have macrophages, T cells, and humoral antibodies that are also stimulated, which further destroy the beta cells. glucagon is secreted by the alpha cells. Again, we remember with glucagon, it's going to try to move more sugar into the blood. So all this creates this really hyper or high glycemic levels in the blood. Let's just discuss just a little bit more. As we know with type 1 DM, the body does not make enough insulin. The immune system T cells attack the beta cells and destroy them. Less beta cells therefore means less insulin, and blood glucose levels increase. There is a known genetic mutation in chromosome 6, hence why there's a strong family history of this. As we know, type 1 diabetes tends to start very early in life, right? Think of the 3 P's for symptoms. Polyuria, so extra glucose in the blood is filtered via the renal system. The glucose is then spilled into the urine, right? Glucose itself is osmotically active, and water will follow it. This will lead to the polyuria that you'll see in the newly diagnosed type 1 diabetes patients. Polydipsia, persons will become very thirsty, right, in the effort to replenish all the polyuria that is occurring. Spend another minute on glucagon. Glucagon is a peptide hormone. It's produced by the alpha cells within the islets of Langerhans, right? And in the pancreas, it works to raise the concentration of glucose and fatty acids in the bloodstream. It's considered to be the main catabolic hormone of the body. It helps us maintain blood glucose levels between meals and also during periods when we're fasting. Glucagon has the ability to initiate glycogenolysis in the liver for a quick release of glucose when it's needed, right? This is going to be largely absent in individuals with type 1 diabetes. It will also gradually diminish in type 2. So just like everything in this course where we talk about these balancing scales within the body to maintain homeostasis, you also have amylin, right? And amylin is responsible for the suppression of glucagon release in the non-diseased state. And that way it helps maintain adequate and normal blood sugar levels. But when we have changes to that, like with type 1 diabetes, this then will lead to the hyperglycemia that we all know is associated with it. And type 1s will also necessitate daily insulin to help control their blood sugars in a more normal state.
So let's spend a few minutes and talk about DKA. We're going to start with what happens in the non-disease state, so aka without diabetes. Without diabetes, you have the pancreas that produces insulin. The insulin is able to combine with the glucose that has come in from food in the blood sugar to move the appropriate amount of glucose into the cells. Now, obviously, when we have diabetes, we do not have that ability, right? We're losing the ability of those beta cells to produce insulin from the pancreas. It leads to hyperglycemia, more glucose in the blood, and so we're going to have more of that trapped. And without that current, without that carrier of insulin into the cells, right, it stays in the serum, and that's where we start having the increasing amount of sugar within the blood. So in individuals who have type 1 diabetes, there is this potential for DKA. I think I was telling you in class that many times individuals who don't know they have diabetes, usually on the younger side, will actually present with their first episode in the hospital in DKA. It's kind of one of those things we use to help with the diagnosis pattern. So DKA often has a very sudden onset, and it starts with a severely insufficient amount of circulating insulin. And when we start having not enough insulin, right, it's not able to move into the cells. The body needs energy. So what's the body going to do? It starts breaking down fat. Okay? When we start breaking down fat, then we have the byproduct within the liver of all that fat breakdown of ketones. when we start having, so as the fatty acids get broken down into the ketone bodies, this is what the cells are going to use for energy. But the ketones are going to build up in the blood, okay? And this is where you're going to start having the spilling of ketones into the urine, which is something you can measure on a simple UA. You may also have the assessment of that real sickeningly sweet breath that can come from patients that are in ketosis. With this over-release of ketones, as it continues, it really starts to increase the acidity of the blood. And this is what leads the person into metabolic acidosis, right? Driving down that pH. When the body tries to create its homeostatic mechanisms, right, to rid the body of all those extra hydrogen ions due to the metabolic acidosis, this is why we start seeing those Kussmaul respirations, right? Those fast, deep type of breaths that are really, really common finding in people with DKA. And they're doing these Kussmaul respirations because the body is automatically trying to increase that respiratory rate to blow off more carbon dioxide and hopefully help bring the blood pH back to the normal of 7.35 to 7.45. We have to remember, though, that often this is precipitated by an infection. So the person is already in an immune compromised state, right? And with having type 1 diabetes, it doesn't leave them a lot of reserve, right? They already have this chronic disease process going on. So we start seeing them kind of spiral a little bit more into what a sepsis presentation would look like, right? Meaning high heart rate, lower blood pressure, dehydration, and really, really high sugars, anywhere around 500, 600, 700, even 800 grams per deciliter. So really, really high amount of blood sugar. In addition to all the other components I just talked about with acidosis, we also need to be worried about potassium. Acidosis in diabetic ketoacidosis leads to hyperkalemia. And this is because the cells exchange all those excessive hydrogen ions with potassium. In addition, as I was talking about in class, because insulin helps potassium enter the cell, right, via the sodium-potassium pump, the lack of insulin that the person is having means that there's more serum potassium that's going to stay outside the cell, and this further compounds the hyperkalemia in the presentation. So many different etiologies. Like I said, most often I have seen in my clinical practice infection as the main causative factor of bringing someone into the critical care setting in DKA. But there are many others, as you see on this slide, including the typically non-disease state of pregnancy, right? So it's not always infection is what I'm trying to say. But there are different assessment key components that you should be looking for. And the signs and symptoms here are the main ones, right? Because the person is becoming very, very dehydrated, you can see where any of these signs and symptoms can further potentiate the risk of mortality associated with DKA. So I want to just spend another moment or two talking about hypokalemia, because in the serum, you're often going to see hyperkalemia. But the overall body storage, the one that's in the cells, is going to be low. And that's because, again, as we were talking about in class, we need the insulin to be present to help assist potassium through the sodium-potassium ATPase pump within the cells. And when we start to have a really high amount of serum hyperkalemia, but no insulin to drive it into the cells, then that's an issue, right? It's really important that we do not overtreat hyperkalemia when a person has DKA. Once we start the insulin drip and help bring that blood glucose down a bit, even into the 300 or 400 range, you're going to see that hyperkalemia is going to be resolved because insulin is going to be in there to help push the potassium back into the cell where it needs to be. Okay. You will also see phosphate depletion with DKA. And again, as you start the insulin drip, you will see that this will start to normalize. If the person is having large amounts of fluids, you may see some dilutional hyponatremia or low sodium. Due to the profound dehydrated nature that brings in a person to the critical care setting in DKA, you will undoubtedly see that elevated BUN and creatinine levels. Once we get them hydrated up, which can be anywhere from 8 to 10 liters of saline in 24 hours, then we'll start to see a more true effect of the BUN and creatinine. So now let's take a few minutes and look at the opposite side of patients who have subsequent bad infections or maybe surgeries that have type 2 diabetes. And these ones have a very similar presentation in the critical care setting to DKA, but are termed hyperosmolar hyperglycemic states, or HHS. I've also seen this referred to as hyperosmolar hyperglycemic non-ketotic state, so HHNKS. So with both of these disease processes, you see that there is an overall decreased insulin within the body. Now, with the differences in the type 2 diabetic, they tend to still make a little bit of insulin. And just that small amount that they're still able to produce really helps to not put the person like in DKA that is utilizing the adipose tissue for energy. Instead, you have this breakdown of peripheral tissue that leads to an increase in amino acids that starts within the liver. You can see the process here with the gluconeogenesis, creates that high amounts of sugar levels in the blood. And with this, you start having this overwhelming osmotic diuresis. Like what I drew on the board. You remember you had that hyperosmolar state. And when you have that, the body is going to try and rectify that by sending more fluids, right? To bring it down to a normal osmolar state. So when you have this draw of fluids from the tissues into the vasculature, you're going to have this profound dehydration in the tissues, and with the osmotic diuresis, you're actually going to have profound polydipsia and polyuria. So you're going to have this really high amount of urination. You're also going to have a really high thirst. That's not going to be able to keep up, though, with the amount of osmotic diuresis that is happening. So like DKA, you're going to be dumping a lot of fluids into this patient, anywhere from 10, 12 liters. I've even seen where we've had to give even more in a 24-hour period in a person with HHS, even more than a person with DKA. So again, the treatment, though, it does become about the same. You have the fluids, you give large amounts of fluid resuscitation, you often will have an insulin drip. You're monitoring all of their electrolytes on a nearly hourly basis, including blood sugar. So these people are often in the ICU setting for quite a few days until we can get them under control. Now, one of the key differences, without the ketone production, HHS, you don't generally have an elevated anion gap. Again, another summation slide. This one's directly from your book, and I think it shows the pathophysiology of both of these diseases. Again, looking at DKA for more of the type 1s, diabetics, and HHS for type 2s. Both of them yield a hyperglycemic state due to insulin deficiency. From this is where they do differ a bit though. DKAs will utilize the fatty components, which leads to ketone formation and metabolic acidosis. With the HHS, you see that overwhelming osmotic diuresis leads to high amount of urine output, can lead to a host of electrolyte imbalances and worsening of renal function until we are able to autocorrect that. So in a test question, if I gave you a scenario and there was a presence of ketones in the patient, or in presence of ketones in their urines, or maybe that sweet smell to their breath, you would know that this is much more of a DKA type of patient versus an HHS type of patient. Okay, so now let's talk about the adrenal disorders. So this slide just provides a little bit of a summation of what you should be thinking about with acute adrenal insufficiency. Again, most of the time you're going to see it from a primary component where there is direct assault or some type of destruction of the adrenal gland. Secondary comes from use of medications and or procedures that may have interfered with the secretion, right, of these glands. The main two components that we look at is the subsequent lack of cortisol and lack of aldosterone when it comes with this. So again, it's generally fairly rare, right? But when this insufficiency occurs, the body isn't able to produce enough of these two hormones, and again, particularly aldosterone and cortisol. Now we remember that there's two adrenal glands above each kidney, and each one, they're made up of three layers, right? The zona glomerulosa, the zona fasciculata, and the zona rectalis. You don't need to memorize that. That's from your A&P days. For the outermost layer of these adrenal glands, that's the zona glomerulosa, right? And that's full of the hormone these cells produce aldosterone. And I always remember that because glomerulus is in the kidneys and it's the zona glomerulosa. So that's how I remember which part of that makes aldosterone, right? And with aldosterone, as we know, there's a big component of aldosterone that is in our blood pressure control, right? We're going to talk more about that in a slide or two. We also have cortisol. Right? That's the other big hormone. Cortisol is utilized by the body for the flight or fight mechanism. It promotes a rise in the blood glucose concentration, right? And this occurs because cortisol stimulates the breakdown of fat and protein. And this converts into amino acids and goes to the stores in the liver to increase gluconeogenesis, right? And this is what allows for blood glucose to be maintained even in times of fasting, right? It's one of those homeostatic mechanisms that we have in our body. So any insufficiency in the adrenal glands can really throw out a lot of different components that we need to consider.
Let's just look a little bit more in depth on some different disorders that come. Addison's and Cushing's, you can kind of compare and contrast with the depiction on the right. Probably the most common picture is this one of this little boy. I think I've seen it in every Patho text since I've been in school from the 90s, where this is actually the same child, believe it or not. So you start seeing where Cushing's disease and Cushing's syndrome from the excessive cortisol really takes effect. I mean, look at the moon phase, the weight gain, the hair changes in this little boy. So it makes a profound difference with this. So let's look at it a little bit more. When you start having chronic hypercortisolism, it inhibits both the hypothalamic cortical-releasing hormone, or CRH, that we talked about before, and also vasopressin secretion, as well as ACTH secretion by the normal pituitary corticotrophs. So the hypercortisolemia associated with Cushing's disease is usually due to the ACTH producing pituitary hormone. So that's where you have the Cushing's disease presentation. With this, treatment really needs to be directed whenever possible at the primary cause of whatever is causing the syndrome, right? So like I said before, this picture that you see on the bottom of the screen is actually of the same child. But people with Cushing's syndrome will have one or more of the following, right? The weight gain, especially within the face, the neck, the belly, and the back. They tend to have very thin skin. They tend to bruise more easily. They may have a higher incidence of these reddish purpley stretch marks. They might have present with oilier skin and acne. They often will have weak muscles in both the upper arms and also the legs. So a good way to assess this is have the patient try to raise from a chair position, a chair with arm support. Have them try and raise up and stand up from a chair position and just see how much their musculature has been affected. Oftentimes their bones also become much more fragile, and they may suffer more breaks too with Cushing's syndrome.
So let's remember what aldosterone does in our body, right? It's a vital part of the renin-angiotensin-aldosterone system. It has a big component of maintaining adequate blood volume and adequate blood pressure in the non-disease state, right? Aldosterone has the ability as a hormone to decrease potassium levels by enabling its secretion and excretion into the urine, and also increasing sodium levels serumly, which then water will follow, and again to maintain adequate blood pressure. So it makes sense when we have lack of aldosterone, we're going to have the opposite of everything we just described, right? We're not going to have that increase of sodium. We're going to have loss of sodium, which then water is going to follow it. So we're going to have a decrease in circulating volume. We're not going to have that automatic regulation of blood pressure that you're going to have. We're also going to, of more concern is going to be that we're going to have potassium retention, and that can lead to a whole host of issues. As we know, this severe hyperkalemia can interfere with the electrical conduit of the heart, right, leading to ventricular arrhythmias and potential cardiac arrest. So this is why we need adequate levels of aldosterone, and individuals with acute adrenal insufficiency are going to lack this. So this is where we need hypervigilance in terms of critical care monitoring of cardiovascular function, of renal function, and overall body volume function. So again, just some brief descriptions, trying to incorporate some of your previous knowledge into situations where adrenal insufficiency could come in. Again, not for memorization, just more for clinical knowledge. But most commonly, you will see Addison's disease as the most common causative factor in acute adrenal insufficiency. If it's more a long-term, chronic type of situation, then we can look into the Cushing's syndrome as well. Again, in differentiating primary, we're looking at a direct causative factor. With secondary, again, it can be something else that has been treated for another issue that has now led to acute adrenal insufficiency. Okay, so now we're going to talk about thyroid disorders. You remember that your thyroid gland produces two main hormones, right? T4 and T3. And these two hormones influence nearly every cell in your body. They maintain the rate at which your body uses fats, uses carbohydrates, It helps control overall body temperature, can influence heart rate, and also can help regulate the productions of proteins within the serum. So applying the concepts of the assessment for the thyroid storm, again, we are looking at a hyperthyroid state, elevation of T3 and T4, right? Let's go back to the normal system, right? And in the non-disease state, how does the body regulate this, right? It uses, the hypothalamus uses this positive and negative feedback systems to kind of control the amount of TRH that's going to be sending, right, to then create into TSH, thyroid stimulating hormone, which then has the effect on the thyroid gland itself. So when we hit to thyroid storm, we have this constant innervation upon the hypothalamus that is releasing TRH to subsequent TSH that's going to then act on that thyroid gland to keep pumping out T3 and T4. Over time, the person's not going to be able to tolerate this. It's not a hugely common thing you've seen in the acute care setting, but it does have a fairly decent mortality rate of about 20%. It is more commonly found in individuals who are assigned female at birth than those that are assigned male at birth. It's like a 10-to-1 ratio. I don't know the reason why for that. But it is much more commonly seen in women than men. And again, because we're in this hyperbolic type of state, any comorbidity such as heart failure, right, or even COPD emphysema, it's going to put this person in this constant sympathetic nervous system innervation, right, due to this hormone response of T3 and T4. And this could lead to subsequent MI. This could lead to a whole host of other complications due to the increased oxygen demands of the body due to the hypermetabolic state.
Okay, let's, the next couple slides, look at parathyroid function and what does it do in the body. As you can see, there's the key takeaway point from all this is parathyroid and calcium levels are really, really closely related. If you have hyperparathyroidism, you're going to have an increase in PTH. You're also going to have an increase in calcium in the body and all the complications that can come with that. Subsequently, hypoparathyroidism is a decrease in parathyroid hormone, decreased calcium in the body. So let's just break it down a little bit more in case you're not as familiar with this. The parathyroid is composed of 4 small glands that you see here, embedded in the posterior aspect of the thyroid gland. And again, as I said before, the main function is production and secretion of the parathyroid hormone, or PTH, which is a polypeptide hormone responsible in that maintenance of that serum calcium homeostasis. So when we have low serum calcium levels in the body, parathyroid hormone will be activated in conjunction with vitamin D to work at many sites in the body to mobilize calcium stores to increase serum calcium levels. Both calcium and vitamin D provide negative feedback to the parathyroid glands. As levels of calcium and vitamin D increase, they will bind to the receptors within the parathyroid gland themselves to inhibit the production and release of PTH. So again, you see this negative feedback that you see in so many other endocrine functions within our body. So let's spend a little more time taking a systems approach of the effects of parathyroid hormone. Again, we know that PTH, its function, the gland itself, its function is to maintain serum calcium homeostasis, right, through synthesis and release of PTH. So within the bones, within the skeletal system, parathyroid hormone works at the cellular level by indirectly stimulating osteoclasts. Remember osteoclasts, those are the ones that break down the bone. So PTH binds to the cell receptors on the osteoblasts, stimulating the release of receptor-activated nuclear factor kappa B ligand, better known as RANKL, that we discussed in the MS lecture. And with RANKL, you're going to have this bind to its receptor on the osteoclast precursors, and it stimulates them to fuse into mature osteoclasts, thereby increasing calcium reabsorption from the bone. Again, it's doing this to maintain appropriate blood levels of calcium, right? That's the whole effect of this. Let's look at it at the kidney level, the renal system. Parathyroid hormone has two main roles in the kidneys. It works, again, as we discussed before, in the thick ascending loop of Henle, the distal convoluted tubule, and the collecting ducts to increase reabsorption of calcium. And it does this by upregulating a certain calcium transporter on the tubular epithelial linings. So we also know that parathyroid hormone binds to sites within the proximal tubule to block phosphate reabsorption. Therefore, you're going to have increased phosphate excretion in the urine, but also blocking calcium excretion. So I guess calcium is going to go up, phosphate's going to go down and be excreted by the urine. You're also going to have parathyroid hormone that works on the proximal tubule of the kidneys to upregulate the translation of something called alpha-1 hydroxylase. No need to memorize that, but this is an enzyme that is responsible for generating the biologically active form of vitamin D. Vitamin D, as we remember, binds to receptors within the bone that function similarly to parathyroid hormone, and this is going to increase serum calcium levels. Within the GI system, calcium absorption occurs in the small intestines, with approximately 75% of all serum calcium going to be absorbed in the ileum. So parathyroid hormone has no direct effects on the small intestine, but what it does have effects on are vitamin D receptors that are present there. So vitamin D receptors occur along the entirety of the gut epitheliums. And this is where, again, you're going to have that capture of calcium from the foods we eat with proper vitamin D to allow for that proper transcription and translation of the calcium proteins into the serum calcium levels, thereby increasing serum calcium. So you can see it has a wide effect from just these small 4 little glands embedded within the posterior thyroid gland itself. Again, just a bit of a slight cheat sheet might be helpful in studying for the exam and kind of associating the who and what for endocrine pathophysiology and what are some of the subsequent responses of the body that you'll see and some of the common disease findings. Okay, I know this is a long one. I apologize. Please let me know if you have any questions on this module.